Introducing myself, I do know a number of you. My name is Jane Malkivich, and I was an inpatient clinical social worker for the Department of Mental Health at Worcester State Hospital and Worcester Recovery Center for about 35 years before I retired a few years ago. And now I work part-time for DMH, working on special clinical projects. And one of the main projects I've been working on the last few years is treatment planning. So about 3 years ago, the department asked me to put a group of people together from all different facilities. And I recognize there are some people on the call today that were on that committee. And we got together to develop a new master treatment plan that was going to be used at all the facilities. And so that's the main thing I am going to be talking about today. We also developed documents for the admission treatment plan, or what you know now as the initial treatment plan that people do on admission. But the documents we were using did not meet Joint Commission and CMS requirements. So we made some changes to those documents, and I will be going over those new admission documents today as well. Okay, so this is going to be 2 sessions. The first session is today, the next session is in 2 weeks. And today what we're going to do is provide an overview of the treatment planning process, define what is meant by active treatment, understanding the case conceptualization, the thinking behind developing a treatment plan, and how to translate what we do into documents, and identifying and writing SMART goals. So the DMH Treatment Planning Committee outlined what training we thought people should have. This is half of it. The next half is next week. And we thought, in addition to going over the new document and how the new document works, we felt that everyone should have training on the basics of treatment planning, because not everyone has had them. And I know there are a number of you that work at the Fuller who know a lot about writing good treatment plans. And I encourage you to speak up and ask questions during this training, because the more minds we have, the better. Okay, so you may be thinking, why bother with this stuff? Nobody follows the plan. Nobody reads the treatment plan anyway. This is the case in a lot of places. It's kind of like a piece of paper that we fill out when we're meeting together with the patient, but it often does not reflect what treatment we're really providing to the patient. And the other thing is where the treatment plan is the only document that we are writing specifically for the patient to be able to read and understand their treatment. So those are reasons we have to pay careful attention. And if it's not now a living, breathing document that you're using that changes as the patient progresses and changes, then our goal is to move towards that. So people often ask me, what are the CMS and Joint Commission standards around treatment planning? Okay, so here's a synopsis of right directly from Joint Commission documents. The organization develops a plan for care, treatment, and services that reflects the assessed needs, strengths, limitations. The plan must include clearly defined problems and need statements, a substantiated diagnosis, measurable short-term and long-range goals, the specific treatment modalities utilized, the responsibilities of each member of the treatment team, the frequency, care, treatment, and services provided, and the plan needs to be reevaluated and, when necessary, revised at a minimum specified time interval established by organizational policy. Okay, so here's the basic Joint Commission CMS standards. Now, you are already following all these standards in the treatment plan that you're using now. But we made what we thought would be a number of improvements. The new treatment plan, if for those of you seeing it, looks very similar to what you're using now, but everyone who uses it finds that it's much easier to use, and it's much cleaner. There's nothing on there that doesn't belong on a treatment plan. There's no extra information. So people seem to like that about the new treatment plan. Okay, so we also want to talk today about patient-centered treatment, because one of the issues with the treatment plan that you are using right now, it doesn't, the format does not make it easy to make it a treatment, a patient-centered treatment plan. So on the document you're using now, after you've done the whole treatment plan, right at the end, it asks the patients if they have any comments. And what we want is, we want patients to have their goals front and center. So in the new treatment plan, that's the first thing on the treatment plan. But we also want to encourage everyone to make their treatment plans as patient-centered as possible. Okay, now we understand we work in a hospital. There are hospital regulations that we have to follow. There are no exceptions to that. But our goal is to include the person as much as possible to the extent that they are able. So just another word about the Joint Commission. The surveyors will be expecting to see consistent application across an organization's setting and services. Otherwise, they may inquire about relevant policies, procedures, training, and monitoring. Now, as I said, I worked at Worcester State Hospital and the Worcester Recovery Center for many years, so I am very familiar with forensic admissions. And I know that the majority of your admissions are from the court, as they are at the Worcester Recovery Center. So I want to try to address that, and I'd like people to ask questions as much as possible, because I know at Worcester, people that work all our court evaluation patients come into 2 units, and they're all together. And the people that work there often get very frustrated with the treatment plans, because they don't feel that our treatment plans are suitable for, people that are coming in on 20-day evaluations and things like that. So I've done a lot of work with them about how to make sure that they can do a treatment plan that meets all the standards, but is still relevant for somebody who's only going to be there for 20 days for an evaluation. Okay. So what is active treatment? People ask a lot about active treatment. What is active treatment? This is a direct quote from a Joint Commission document. Active treatment is a clinical process involving ongoing assessment, diagnosis, intervention, evaluation of care, and treatment. Okay, so active treatment is not static. It changes based on the person's progress or setbacks, and everyone who works with them evaluation of what their needs are and what their diagnosis is. So it's ever changing. That's what active treatment means. It's not what you do with every one of your patients that's routine. It's what you do specifically with this person that's in front of you now. And it must have a trauma-informed, person-centered, and recovery-oriented lens. And the Department of Mental Health has long had the stance that all of our treatment should be trauma-informed. And why that's important is that the majority of our patients have serious trauma histories. And some of them might not remember their trauma histories. They might not acknowledge their trauma histories. They might not feel comfortable sharing their trauma histories with them. but the majority of people that come to us have had some very serious trauma. So we need to treat everyone in a trauma and informed way. And it's just good treatment practice to treat everyone that way as well. Okay, active treatment is a collaborative process with the person served and begins with clinical assessments of each person's needs. So when someone comes into the hospital, we do many assessments. And the assessments that people do with DMH are really excellent. I mean, I have never seen any other place that does as good of comprehensive assessments as we do in the Department of Mental Health, okay? And those assessments are the basis for the treatment plan, okay? And it needs to be a multidisciplinary approach with input from all providers involved in the individual's care. Okay, active treatment is individualized treatment that is continually changing based on the person served changing needs. It is not simply a description of what staff does with every individual. Now, what that means is active treatment is not just passing out medication. Active treatment is not just meeting with a patient to do discharge planning. Active treatment is not doing any of the routine, regular things that you would do with people. It's not just having somebody attend a group, any group, okay? Active treatment is targeted towards the person's long and short-term goals that are on the treatment plan. So it is what you are doing with this individual patient that you're not doing with everyone else. So let's just take passing medication, because most of our patients take medication. So if you're the person that's passing out on the medication, you know your clients, and you may do something a little different when each one of them comes to the med door. You may have some people who have a history of not taking their medications, and you might have to do something special with them, like you know, put it in applesauce or have them wait, or you may have to be somebody, do some education with them. That's active treatment. Those individualized things that you do with patients that you're just not doing with everyone else. That is what we mean by individualized active treatment. Okay, active treatment incorporates the person's serves strengths and recovery goals. Okay, so I would like to stop right here. This is the end of the section on active treatment, to see if people have any questions or comments. And you can just unmute yourself and talk. And I'll check the chat box here too. Oops, went to the next one. Okay.
Hello?
Yeah.
Okay, so I was saying, I believe when a person's strength might be their ability to participate in their treatment plan actively or to advocate for themselves.
Can you repeat that? My hearing is not that good.
Okay, I was saying a person's strength could include their ability to participate actively in their treatment plan.
Yes, absolutely. Yes, absolutely. And their ability to participate in their treatment plan is going to change over time. So when someone comes in, they may not be able to participate a whole lot in their treatment plan, or they may want to. You know, our clients do not come in voluntarily. But as time goes on, that could and may change. So we want to pay attention to that. But that's an excellent point in terms of what might be a person's strengths. And we're going to talk a little bit more about people's strengths as we go on. Okay. Okay. So we look at treatment with the recovery lens, and the recovery lens holds the central idea that people can and do recover from mental illness. There actually was a time in my lifetime when a lot of people didn't believe that. They believed that, like, if you had schizophrenia, well, you were always going to have schizophrenia, but they didn't believe that people like that had schizophrenia were going to be able to, a lot of them, back in the day, we used to have a lot of people hospitalized. There were a lot of people that people thought could never leave the hospital. And a lot of those people, most of them have left the hospital, and some of them have done very, very well in the community. So it's a very different approach from, say 30 or 40 years ago, as we know more about mental illness, and we know that there's more to treatment than just treating symptoms. So medication is extremely important because a lot of new medications have been developed over the years that are really great at treating people's symptoms. But medication isn't enough. We also need to help people to rebuild their lives to have a life worth living. And so recovery includes a lot of what we do. And you're doing it there in the Fuller, and that's what our treatment plans need to reflect. Okay, so we're going to talk a little bit here about including the role of the person in recovery. The individual in recovery is encouraged to participate to the maximum extent possible in all treatment plan meetings. Okay. So there are people that, even if they've been there for a while, I'm sure you have people like this there that just never come to treatment team ever. But if you continue to ask them every week, someone will surprise you one day and start showing up. So it's important that even if we have people that don't come to treatment team meetings, we should make sure that they know when they are and invite them into the meeting, even if they, have told us, the last 10 times they don't want to come. The level of involvement and self-direction varies based on personal preference, as well as time and stage in recovery and level of interference from active symptoms. So a lot of people struggle with the idea of patients being very involved in their treatment because they've experienced people who can't do that or don't want to do that. And we have to remember that we are not only a hospital setting, we are in a state hospital setting. And like I like to tell my patients who say to me, I didn't do anything to get in here. I don't belong here. And I'm like, well, let me just tell you what I know. I know it's really, really, really hard to get in here. So something must have happened in your life that caused you to end up here, because it's not easy to get in here. We get the most difficult people in the state of Massachusetts, and we get people from world-class hospitals that couldn't help them, and they come to us and we work with them and we help them recover. So we are very, very good at this. Okay. And we are good at engaging people that other people might see as not engageable. So the third point is a really good one. Many individuals benefit from education preparation in order to overcome fears or other factors which might influence their participation. So at some facilities, they have designated certain staff to meet with patients before the treatment team meeting. There are even like worksheets that they can fill out to prepare them to go into treatment team meeting. And it just makes sense because the analogy I always use is I go see my primary care physician like once a year, and it's just me and him, or he might have a medical student. But when you're walking into a treatment team room, you're walking into a room of oftentimes, not these days, because I don't know if you're still doing yours on Zoom. I know other people are doing them on Zoom, but you're walking into a room full of people, and you may, if you're new, you may not even know some of them, and it's very intimidating. But even when I go to my doctor, who I know, and I'm the only one in the room, if I don't make a list of all the things I want to talk to him about, I am not going to remember. Okay. And it's the same thing with our patients. I mean, oftentimes they'll walk out of the room and then an hour later say, oh, I wish I could have talked to my treatment team about this. The other thing is that when my experience with patients coming into treatment team meetings is they often ask about what their immediate needs are for the next like day or two. Okay. So without some support, oftentimes people don't come in and want to discuss what are all things that I need to do to get out of the hospital and how am I making progress. They want to know if their medication can be changed, can they go smoke, can they go get something to eat, can they get privileges. Those are most of the things, their immediate needs. And so we really have to help people to think more about their long-term goals when they come into the treatment team. And what I mean by long-term goals, if somebody's in the hospital, is getting out of the hospital. What do you need to get out of the hospital? If you notice here, we have a couple of slides by Greta and Tondora. Janice Tondora is a psychologist at Yale, and she actually has done a lot of consulting with Tewksbury State Hospital on doing patient-centered treatment planning. And she was up there about a year and a half ago for 2 days, and they invited me up, and I spent a day there going to her workshops, but also I sat down with her and she reviewed this new treatment plan line by line with us and made some suggestions, and really liked what we were doing with the new treatment plan. Okay, goals. Everyone has them, and everyone has the right to try, facing risk, adversity, and roadblocks along the way. Goals need to be meaningful to the person. It's their life, and we need to encourage them to define it. Okay, so especially when people first come in and we're trying to talk to them about their goals, our reaction to their goals is often that this is really unrealistic, or this is so far beyond, maybe they could reach this goal, but we're talking about years from now, not in the next few months. But it's important that we listen to what people have to say. One of the common ones that I encountered as a social worker was I would have clients who would tell me they wanted to go live independently. And it was something they had not been able to do in a long time. And it was clear to me that they didn't currently have the skills to do that. But instead of saying, no, you can't, the treatment team has decided that you have to go to a group home, you can't live independently. What you would do in a patient-centered approach is you would explore that with someone. Okay, so you want to go live by yourself. Let's talk about this. These are the things you have to do. You have to have a budget. You have to do this. You have to do that. And I find as you go through that process with people, oftentimes, not always, oftentimes they will end up coming to the conclusion, and I'm talking about over a matter of weeks and months, that, yeah, I really can't live independently, or they may even try to even get to the point to where find an apartment and they just feel too overwhelmed or whatever. But, what patient-centered treatment means meeting the person where they're at and listen to what they're saying, and not saying there's no way you can't ever do that. So this is a slide that we did not create. This slide, this came from someone else, and it is a slide about person-centered approach. But what's interesting about this slide, it mirrors our new treatment plan. So it starts out with the individual's life goal as defined by the person. Okay, now you're going to have people coming into the hospital, and they, if you're going to ask them, they may not have a life goal, or they may say, I don't belong here. I just want to get out of here. I want to go smoke. All the things that we hear people say, but those are real goals for the people. So, I tell people, if you want to go smoke, we're a non-smoking facility. So in order to smoke, you're going to have to leave the hospital, and we can help you achieve that goal, that kind of thing. But for people coming into the hospital, we really want to focus on what does the person need to do to get to the next level of care, or what do they need to do to get back to court, okay, is the case in a lot of cases. So we're really trying to get people to focus on what do they need to do in order to be ready to leave the hospital. And we draw upon their strengths, we look at their barriers, and then we look at their short-term objectives, which is another word for short-term goals. And they need to be behavioral, achievable, and measurable. And then the service and action steps, that is the interventions that what the interventions are. What is the staff going to do to assist this person in meeting their goals? And those interventions can also include roles and actions by not just people in the treatment team, but natural supporters. Less so we get that in the community. We do have people that have access to their natural supports while they're in the hospital, but it tends to be more so when they're out in the community. I'm just going to let you look at this. So here's a list of phrases, and we use many of them often. And these use deficit-based language. They're looking at the person's deficits. Now, I'm not saying we don't look at the person's deficits. That's part of what we have to do for the treatment team, to do the treatment plan. We have to look at the person's deficits. But people are overwhelmed. The people that we serve have so many things going on in their lives and so many deficits that it's overwhelming, and it overwhelms them and it overwhelms us. And we often lose sight of their strengths. It's their strengths that are going to help them make the changes they need to make in their lives to make to have a better life and to get out of the hospital. So strengths-based language, which is here on the right, is just going to help engage the person more in their treatment. Okay. And I see patient-centered treatment is engaging the person in their treatment. I don't see how you can engage someone in treatment without a patient-centered approach and involving them, because the work of treatment is very, very difficult, especially for our people. They have mountains to climb, okay? And the work that they have to do is very difficult. We cannot do the work for them. We can support them, but they have to do the work. And in order to do this really hard work, they need to have some kind of motivation. So their treatment has to tie into something that's important for them. Okay, so I want to talk about, this is a slide about breaking things down from larger problems into smaller problems. And this is not a sharing exercise. Nobody's going to share. Everybody's going to do this silently to themselves. But I think it's an important exercise to think about how do you get from this huge problem that somebody comes in with to a short-term goal. So I want everybody to take a minute and think about something that's important in your life, and think about something that you would like to accomplish. Okay, so now I'd like you to think about all the things that are getting in the way of you accomplishing your goal. Okay, now everyone should be feeling very overwhelmed because there's probably a lot of things that are getting in the way of you accomplishing their goal. So where can you start? So think about one small thing that you can do, like over the next week, that will help you to achieve your goal. Okay, so again, I'm not going to ask people to share, but let's say that the thing you want to do is you're not getting enough sleep at night. You're getting only 6 hours of sleep, and you want to be able to get 7. And so one thing you might want to start with, one thing you might say you're going to start, okay, well, then I'm going to go to bed earlier, an hour earlier, every single night. Okay. So are you really going to be able to accomplish that goal realistically? Okay. You've been going to bed at least an hour later for months, if not years. And now all of a sudden you're going to go to bed an hour earlier, and you're going to do it like every night. That's not realistic. Okay. And this is analogous to what we do with patients when they're helping them to set up goals. We often set up goals that are not realistic and can't be accomplished in a short amount of time. So what would we do with this sleep goal? So if instead of saying you're going to immediately change your sleep cycle by going to getting an extra hour sleep every night, maybe you can start by getting an extra 10 minutes or 15 minutes instead of an hour. And maybe instead of every night, you can do it 3 times over the next week. Because what we want people to do is we want people to do things that they can actually accomplish, so that they feel they're getting somewhere and they don't give up, because the problems our people have are overwhelming. Okay. So the other thing we want to incorporate in treatment plans is we want to incorporate people's strengths. Okay. So say that this person that wants to go to bed earlier, say they like to say they like to do yoga. That's a hobby of theirs. So we would use that in terms of helping them to reach their goal. If that's something that you like to do and you enjoy, maybe you can do some yoga stretches, like for 10 minutes at a certain time each night, to help you settle down. Okay, that kind of thing. If somebody likes journaling or writing, then you might suggest journaling as part of how they accomplish one of their goals. That's what we mean by strengths. It's not just, the obvious strengths that people have, but what are the strengths that people have that we're going to be able to incorporate into their treatment. Okay, so I want to stop here again and take a break and see if anyone has any questions. Okay. We will have a lot more opportunities as we go on. Okay. So the people that come into us come in with a lot of issues and a lot of problems. And what we need to do in the treatment plan is we want to really, really target that to what do we need to focus on to help them to get out of the hospital. So we want to think about what brought the person into the hospital and what needs to happen to help the person towards discharge. Our goal is not to help people to be really good inpatients. Our goal is to help people become really good outpatients, which is a lot harder to do. Okay. So this is an example. This is an example of what we don't want to do when we're writing problems. And, you know, so I just want to talk about this because, you know, I have seen problems like this in the past some places. So in this case, the problem and barrier is non-adherence to medication in the community, resulting in assaultive behaviors, as evidenced by history of stopping his medications, resulting in assaultive behavior and rehospitalization. Okay, this could describe, you know, 90% of people that come into the hospital, right? It's not specifically targeted to this person, and it's way too general to really address. It's going to be helpful to anyone. So pretty much everybody that comes into us is not taking their medication when they came in, but the issue is what led up to that, and that's what we want to do. So when we're doing our assessments of people, we really want to get into the details of what led them to stop their medication and come into the hospital, and what exactly did they do? What do you mean by assaultive behaviors? Did they slap somebody? Did they hit somebody over the head with a metal pipe? I mean, we want to describe it. And I know, because I've looked at your treatment plans, I know you actually do this in a lot of cases very well. You are describing not just that the person got charges, but what the behavior is that resulted in the charges. Okay. So when you do by evidence by, you just don't want to say as evidence by assault charges. You want to say as evidence by and what the person actually did. You can say the word assault charges in there if you want to, but you have to also describe the behavior that led to the assault charges. And then we have a long-term goal here. Mr. K will acknowledge his schizophrenic disorder and the need for medications to manage his symptoms. Well, that would be nice, but somebody doesn't have to do that to leave the hospital. Some people never agree with the diagnosis that we give them, but that doesn't mean that they can't get better and leave. And they may never acknowledge the need for medication the way we would like them to acknowledge it, but they may understand, they may recognize that, you know what, every time I go off on my medication, I seem to get in trouble. So there's a connection here between this and that, you know, that kind of thing. So again, we want to be very, very specific when we're describing problems and barriers in particular. Okay. So we're going to talk about how do you decide which problems go on the treatment plan. Okay. And I think the most difficult decision that crops up is what medical problems do you put on there? Do you put all of them on there? Do you put some of them on it? How do you decide what medical problems to go on there? And so we're going to talk a little bit about that at the end of this section. So we're going to go through this section, and that's one of the things that I want us to be able to talk about, because people have a lot of questions about that. The other thing you notice here is suicide, and there is a new Dmh Suicide Protocol, and you have your fuller version of the protocol. And that protocol is saying that if someone has a moderate to high risk of suicide, then there has to be a separate suicide problem on the treatment plan. And we have had people that are have been very suicide risk in years past, because we've done a better job at this. And suicide never shows up as a problem on their treatment plan. So that's something that we are looking to change. Okay, so when you're deciding what problems you're going to have on the treatment plan, the areas to be addressed are the ones that brought the person into the hospital and/or are impediments to discharge and barriers to recovery goals. Now, when you see the new treatment plan, you're going to see that there's a lot of information that flows in from the assessments that gives you information about what you should be addressing. Again, medical problems don't fit into this category because theoretically, no one should be in a psychiatric hospital just for a medical problem. But we do have to include active medical problems that we're doing something beyond standard treatment. So we have a lot of people that are diabetic that come into the hospital. If they are, if the treatment that they are receiving and that they are following through on is working and their diabetes is stable, then it does not have to go onto the treatment plan. Okay, because it's stable with treatment. But if a person comes in or during the course of the hospitalization is having blood sugars all over the place and it's affecting their mood and their behavior, and then that's an active problem, because the staff on the unit are just going beyond taking finger sticks and administering insulin. They're also doing a lot of education and things like that. So that in that case, it needs to go on the treatment plan. Okay.
Excuse me, Jane.
Yeah.
If, for example, let's say someone has high blood pressure and they're on daily vital signs for that, would that then be active treatment, or would that not be?
That I would, now I'm not a nurse, so I want people to chime in, but no, because doing those vital signs and giving medication and doing things like that, that's routine treatment for high blood pressure.
Okay, thank you.
Now, if, let's say the person, it was difficult to get their vital signs every day, they resisted or they refused or they were combative or something like that, then that's an active problem, because you just are not walking up to the person and doing their vital signs. You have to do some interventions to make sure that they're calmed down and that they're willing to do it and all that kind of stuff. So that's active treatment. Do you understand the difference?
I think so, yeah.
Okay. It's not an easy thing, trust me. And people have lots of opinions. I mean, what we're trying to address is at some point in the last 15 to 20 years, we were told by central office that every patient had to have a health and wellness problem on their treatment plan. Okay. And that was because, you know, the research was starting to come out that our patients had many more medical problems than people that aren't seriously mentally ill. Okay. So it kind of made sense, but this is what happened. So lots of the treatment plans had a general health and wellness problem that didn't say anything. It was very general, and it says patient will obtain optimal health, patient will cooperate with this, that, and the other thing. That's not active treatment. And actually, at Worcester, we got cited for it. I don't know if other places got cited for it, because a lot of us were doing the same thing. We got cited by the Joint Commission because it was not active treatment, and it was on every patient's treatment plan. Okay. So that's very different than someone having an active medical problem that you are going to have as a problem on the treatment plan. Okay. So if you look at the new treatment plan, these things in blue and red are all on the front of the treatment plan before you get to write the problems. So this is the input that we're using to determine which problems we're going to have on the treatment plan. So you're going to have the recovery goals of the person served. You're going to have their strengths. You're going to have a list of their risks, and you're going to have acute and active medical risks. Now, some of those are going to be actually listed on the treatment plan when in certain categories, and I'll show you when I show you the treatment plan. And then you're going to have non-clinical discharge barriers that comes from the social workers in that, what's that form that you guys fill out all the time? I forget the name of it.
Discharge ready.
What?
The discharge readiness form.
The discharge readiness assessment. Yes. It's information that comes from there, the non-clinical discharge barriers. There could be other non-clinical discharge barriers that we're not pulling off that, but that's mainly where we pull them off from. And the last thing we're getting information from is the individual crisis prevention plan. So the individual crisis prevention plan, for anyone who may not be familiar with it, is a document that is started by the nurse when a person comes into the hospital. And it's basically what we used to refer to as a safety tool. So they ask the person about what could be triggers in their environment, and what are some of the techniques that they have found that will help them, you know, to reduce their stress so their behavior doesn't escalate. Okay. So that individual crisis prevention plan is actually a DMH regulation that we have to have that. And it's also a DMH regulation that it needs to be reviewed after every episode of seclusion and restraint, which I think people do generally, but it also has to be reviewed at the treatment plan review meetings, because information from this crisis plan is supposed to be used in the treatment plan. Okay, that said, that is not happening a lot. If it's happening with where you are, that's great. But the other thing I just want to let people know is there's a safety committee that has redone this crisis prevention plan, and they've made it much more clinically focused and much more patient focused, and putting some responsibility on the patient. Anyway, that will be coming out in the coming months, and there will be a training on that. But I just wanted people to know what it was, and that it's a very useful, it has a lot of useful information on it, if it's done well, that we should be incorporating into the treatment plan. Okay, another thing I have been asked to emphasize in this treatment plan training is incorporating suicide as a problem into the treatment plan. So the treatment and recovery plan includes suicide risk as a separate problem with goals and interventions, collaboratively developed with the patient to decrease suicide risk during hospitalization and in preparation for discharge. Okay. And so for whatever reason, we've all done it. I, myself included, you know, not put suicide as a problem on the treatment plan. And I think one of the reasons we do that is because we're not sure what our we do interventions that all the time that help people with their suicide risk, but we don't necessarily see that as that. So for example, one thing that is important for somebody who is suicidal is their sleep hygiene. So we may be doing sleep hygiene stuff all the time, but we don't recognize that if this person is suicidal, this is something that's actually going to help them be less suicidal if they're getting enough sleep. So again, this is something that we are all working on. So I have 3 examples here of problems, and I'm going to go over these, and then we're going to take another break for questions. This first one is an example of a medical problem, the way it should be written. So this is someone who has diabetes. Okay, so Ms. Doe is unable to identify the consequences of having high blood sugar levels, as evidenced by Ms. Doe eats foods on a daily basis that result in blood sugar levels of over 300. She complains of headache, fatigue, blurred vision, and trouble concentrating, but she does not believe these symptoms are a result of her diet. Okay, so this woman doesn't like the headaches and fatigue and blurred vision, and she's complaining about it. Okay, but she doesn't believe that the donuts she's eating every day, because she loves donuts, are contributing to these symptoms that she doesn't want. Okay, so this is a case where you're doing a lot of work with her around this, around just education and pointing things out to her and maybe helping her to reduce her donut intake or whatever. So this is how this is an active problem. And I know you guys write a lot of good medical problems. I actually, when I'm looking for examples of problems, I actually go into the Fuller records to find some good examples of stuff. So I disguise all the information when I use it for training purposes, but I have gone into your records to get some examples of good ways of writing medical problems and also other problems. Like I said, your problems tend to be very well written, most of them. Okay. This is the problem of someone who came in onto the court from court. So John reports that, quote, voices tell me to hurt people, which indicates John is a danger to others due to psychosis. As evidenced by, John was charged with assault and battery after he hit a neighbor in the head with a baseball bat. He reports that voices were telling him his neighbor was going to kill him. So what I want you to notice here is that there is a lot of specific information, but there's not a lot of writing. I don't think it might be, some places and some people write a lot and write way too much. Okay. And I've seen problem descriptions that are two paragraphs long, 2 paragraphs long, and they don't say anything. Okay. And so the key to writing, one of the keys to writing a good treatment plan is to be very specific, but very, very precise. So you've got 3 sentences here, and yet you've got all the important information that you need to describe what this problem is. And this is a suicide problem. So Joan has repeatedly told staff, quote, I want to die. Joan is at risk of suicide and self-injury, as evidenced by Joan stabbed herself in the abdomen and was found by a neighbor unconscious in a pool of blood. When she woke up in the hospital, she told staff she wanted to die. She also has a history of cutting her wrists and drinking bleach. Okay. Again, this is 4 sentences, the entire thing, but it tells you a lot about this person. It tells it tells you that her methods are very, very seriously, that she almost died before she came into the hospital. Not only did she almost die, but when she woke up in the hospital, she told the staff she still wanted to die. Okay. Which puts somebody at a higher risk, because a majority of the people, once they've made an attempt, wake up, are usually glad that they lived, and she wasn't. Okay. Okay, so again, I want to stop here and see if there are any questions or comments about writing problems. Okay, we will move on. Let's write with the right word. I mean, the reason, one of the reasons treatment plans are hard to write is that it's really hard to use the right words. And especially when you're, you're in a treatment team meeting, you've got all kinds of people there, you have the patient there, you're pressed for time. And I can tell you in my personal experience, I often volunteered to be the scribe and did a lot of the writing, but I'll tell you, if I'm in a treatment team meeting and I'm sitting in front of the computer, I have trouble putting the right words together. There's just too much going on. It's not easy to do. So the wording of the plan should be specific and reflect the individual's understanding of issues as much as possible. Wording should be objective, not subjective, and avoid jargon, abbreviation, and buzzwords. Diagnoses are not problems. They do not qualify as recovery or life goals, long-term goals, or short-term goals. So we know that, so just being mentally ill is not a problem in itself, because most people that are mentally ill never in their lifetime ever go into a hospital, okay? So mental illness is a piece of why our people come into the hospital, but it's how mental illness affects their behavior that, because most people that come in are a danger to themselves or others, and it's how their mental illness affects their behavior that's the problem. Okay, so now we're going to talk about long-term goals. Long-term goals need to be behaviorally worded and specific. They need to describe what the person served commits to accomplishing between admission and discharge. They should use the person served's wording as much as possible. This will depend on how much the person is able to participate. And they must be realistic given the time frame allotted. So each area addressed, each problem or barrier, whatever you choose to use, must have its own long-term goal. We know that that's how our treatment plan is set up. You've got the name of the problem and the long-term goal. And each long-term goal must have at least one, usually more short-term goals. One of the things I noticed about the treatment plans that I looked at is you do a nice job of having just 1 or 2 goals for the person, and then have multiple disciplines do the interventions. Some places get stuck in the psychiatrist has a goal, and the social worker has a goal, and the OT has a goal. These are supposed to be the patient's goals, not the staff's goals. And so, and even though they might be patient goals, some people have a lot of difficulty taking one goal and having multiple disciplines working on interventions to support that goal. But at least for some of you, it's not a problem because I've seen that done really well on some of your treatment plans. Okay, and again, each long-term goal specifically describes what needs to occur for the patient to be ready for discharge. And here are some long-term goal examples. John will refrain from physical and verbal assaults on others for 3 months. Mr. T will identify specific therapeutic supports in his community that will help him maintain his sobriety within 2 weeks of discharge. This one is funkily written, I agree. I don't know if I pulled this from somewhere or what, or wrote it myself. But what this means is that the long-term goal for this person is that they are able to identify supports that they are willing to engage in once they leave the hospital, and that will help them maintain his sobriety. And he needs to accomplish this goal within 2 weeks of discharge, okay? So maybe a month before he's going to be discharged, maybe he doesn't have to be there yet. But if he's within 2 weeks of discharge, he should already know what services he's going to engage in the community and where they are, and hopefully have contacted them. So that's what that long-term goal means. Ms. Doe will manage her high blood sugars by using a glucometer and self-administering her insulin for 1 month. Okay, so this is a medical problem long-term goal, which means that it doesn't necessarily have to be accomplished before she leaves the hospital. Now, if she's going to live independently, it would, but if she's, or if she couldn't get like visiting nurses or somebody to come in and help her with it, if she's going to need help with it, then those services have to be set up, okay? So, but we do have to have long-term goals for medical problems, even though they don't necessarily have to be accomplished before somebody leaves, if we can provide the supports that they need to be able to maintain stable physical health while they're in the community. So how are we going to achieve these long-term goals? Okay, with short-term goals. Now, a lot of language around short-term goals actually comes from the business community. In fact, the SMART acronym we are going to use comes from the business community originally. So, person-centered short-term goals. Short-term goals are most effective when the words represent the individual's ideas, goals, and strengths. The person served should participate in the goal writing to the extent possible. Okay. And as an example of this Darren Hardy, I looked up, I didn't get this quote, one of my colleagues found this, but Darren Hardy is somebody who has nothing to do with mental health. He works in the business community. The accomplishment of any goal is the progressive accumulation or compound effect of small steps taken consistently over time. Okay, so what are short-term goals? Short-term goals are the steps to be accomplished toward the attainment of the long-term goal. So they have to be related to the problem and the long-term goal. They need to describe what the person served commits to doing to reach their long-term goal. Now, that's ideal. Hopefully they do commit to doing all their short-term goals, okay? And the reason we want them to commit is because they're the ones that have to do it. We cannot do their goals for them. So sometimes people confuse goals with interventions. And the best way to remember this is the goals, the short-term goals are what the patient is going to do and describe what the patient is going to do. And the interventions describe what the staff is going to do. Okay. So short-term goals need to include observable and measurable outcomes and tie back to the long-term goal and the life goal. Short-term goals do not describe what the staff will do. That is an intervention. So it's not a short-term goal that the patient is going to meet with the nurse, or that the patient is going to meet with the social worker, or the patient is going to meet with their psychiatrist. That's not a short-term goal. The short-term goal is what is the patient going to accomplish by meeting with the nurse or the social worker or the psychiatrist, okay? So short-term goals should not say patient will meet with, okay? Because that's an intervention. And maybe not at your place, but for some places, people, that's earth-shattering, because a lot of people write all their goals saying, patient will meet with social worker, it's what is the person going to accomplish when they meet with you? What are they going to achieve during their meetings with you? Okay, so what is a SMART goal? At Fuller, have you been using this term SMART? Or is this new to people? Because I know at a lot of places they've been using BOMA, but for purposes of this training, we wanted to go with one
We've been
acronym.
using SMART goals.
You've been using SMART, okay. So SMART means specific, measurable, attainable, relevant, and time-bound. So these are the criteria by which you judge whether or not your short-term goal meets the standard. So these are the exact same standards that CMS and the Joint Commission have for goals. So that's one of the reasons why we chose the SMART acronym. So for people that might be more familiar with BOMA, what we did was, SMART, and we've got SMART on the left and BOMA on the right. The results are the same. A SMART goal and a BOMA goal look exactly the same. It's just different words that we use. Okay. So short-term goals need to be behaviorally worded, measurable, and have a reasoned target for attainment. If a person is not meeting their short-term goal in a matter of weeks or a month or up to, say, 3 months between their length of stay, then it's usually because either they're not measurable or they're not reasonable, okay, and they need to be changed. They need to name only one behavioral task or condition to measure. Okay, and there may be some exceptions to this, but this is the rule of thumb, because you want people to be able to accomplish something. And if you stick to one thing, the person can more easily accomplish it than if you give two things. So say, let's go back to our sleep example. Say you say that the person who's trying to get an hour more sleep, the person is going to go to bed 15 minutes earlier every night, and they're going to turn off all their tablets an hour before they go to bed. Okay, so those are two good things to have, but you want to focus on one or the other as a goal, because somebody might not be able to do one, but they could do the other. Okay. They must describe a task or condition that can reasonably be accomplished. And we have our little hiker over here that says, it might seem daunting now, but mountains get climbed one step at a time. And this is something we need to encourage our patients to do, because often our patients don't think they're accomplishing anything if they're just doing small steps. They want to do the big steps. And so we have to do education with them. And this is a slide that just demonstrates that expectations and reality can be two different things. So we might come up with a goal with someone that we think is going to be easy to accomplish. And then when the person tries to accomplish it, they have all kinds of difficulty. So that's when we need to change the goals. Okay, this was something we'd be doing live. I'm going to skip over that. So here are some examples of some SMART goals. John will tell nurse if he is hearing voices and what the voices are telling him at least once a day during the passing of medication. Okay. You can see it. You can now you know there's a specific time when you're going to do it. And this is an example of, we actually have two behaviors in here, not one, but the behaviors are so interconnected that it's okay. Because if John just tells the nurse whether or not he's hearing voices, that could be one behavior that we're looking at. But if he's telling the nurse he's hearing voices, you really want to ask what those voices are, right? And then you don't want to ask what the voices are telling him if you don't know if he isn't hearing them that day. So these two things really go together. And I saw some examples again in some of your treatment plans where there had been a short-term goal and it had a couple of things in it, but it was very well written, and to the point where I would say that it was okay. But again, we should really try to stick to one thing. So Ms. Doe will be able to identify one symptom she experiences when her blood sugar is high at least 3 times a week after her blood sugar is measured. Okay. And if she goes for a month and she can't do this 3 times a week, then maybe we need to reduce it to twice a week or 1 time a week. When you change the goals, you don't have to write a completely different goal. You can change parameters within the goal. You can change how often somebody does something. You can extend the goal. So if somebody's able to do something every day for a week, let's see if he can do it every day for 2 weeks now. Joan will report use of 1 crisis survival skill per day for 4 consecutive days on her diary card. And Ms. M will meet with attorney and discuss her charges for 15 minutes. So obviously this would be somebody who has come into the hospital on a 15B, and they come in because she came in because she wasn't able to meet with her attorney and discuss her charges. So that would be one of the goals that would tell us that she is ready and able to return to court. Okay, so I'd like to stop here. This is the end of this presentation, but I have another presentation I'm going to go over with you guys in terms of the admission documentation. So I just want to stop here to see if there are any questions or comments about what we have gone over so far.
Yeah, if I have one about, like the revising of the short-term goals, like in that when our patients are here for like up to 20 days and we're having weekly reviews, if there's not a change in a week, sometimes it's not indicated to change the goal as to give it more time. Yet,
right?
And yet at the same time, like how do we justify that if we were being surveyed?
So I think that's okay, but my question is, have surveyors questioned that with you?
With me personally, no. But like what I'm hearing is that they're looking for the revision or the reassessment of the goal, and if it's not working,
right.
But
yeah,
but within the shortened time,
yeah,
within the compressed time frame that we operate in.
Right. So let me ask you this. What's your time frame for doing your master treatment plan from like how many days after admission are you doing your master? 5?
5 max.
Okay. And so then you're doing a treatment plan review, what, a week later?
Within a week later.
Yeah.
And conceivably with some patients, their return date could mean that they would only have 2 treatment plan reviews in that 20-day period.
So, well,
I give you the easy ones.
No. This is important information because you have to adjust to whatever. No, I've heard, I was aware that, because whenever anyone could complain at Worcester, they'd say, well, at Fuller, they're doing it in 5 days. So, are you, even if they're not going back to court, how long are you doing weekly treatment plans for? Are you doing them for 8 weeks?
Yes.
Okay. Okay. So what I would say, because you're right, because the reviewers, and I've sat through a lot of reviews with the actual reviewers, they will say, let me see your first treatment plan. And then they'll say, okay, I want to see the next one. And they will look to see what's changed, and they expect some things to change. So my advice to you on that would be to create goals that are very achievable in a week's time. Now, I have seen some people do this, okay? So, and here's the thing. You're going to have likely more than one problem. You only need one problem, but you're likely going to have more than one problem. You're going to have more than one short-term goal. If you say you have a treatment plan and there are 3 short-term goals, and the person has met 2 of them in a week's time, but not the 3rd one, I don't think they're going to give you a hard time about that, that you continue that one. But if absolutely nothing has changed, then they might say something.
Okay, because for some of our patients, if we're talking about a decrease in symptoms, impairing their daily functioning, and it's because of medication non-adherence, they won't even have a conversation about that. That probably is not going to change until a decision is made to whether or not they are committable or not.
Right. So you need to think of some other goals. What I can do between now and next week is are your 15Bs, are they on one unit or are they all over?
All over.
Okay. I'll have to find some, I'll take a look at them and see what I can make for suggestions. Because you're right. I mean, if nothing changes, or maybe nothing changes between the first and the second, but then if you're doing a 3rd one, you know, you do the master, and then you have the first one, nothing changes, and then you have the next one. They do look at that. They do want to see some movement.
Jane, just to add on to what George was saying about admissions, although they're all over, we actually are admitting into the 80s unit. And
which unit?
The 80s unit, and people are staying there pending testing, and then pending, actually even after a negative test, pending 14 days. So,
okay.
So 80s unit is the unit to look at people's admission date.
Okay, thank you. That helps, because I can go in unit by unit, and if I know that unit, that will help me a lot. Okay. And this is a challenge. I actually did, when I did the training at Worcester, I trained the court evaluation staff separately. And I've done a lot of follow-up with them because it's a challenge. You know, all these regulations were not written for people coming into the court for a 15B. They just weren't. And then we have to figure out how to do this for these clients because these clients are in a psychiatric hospital. we have to do all the same things for every client regardless of their situation, and they are different. And so anything I can do to help with that, let me know. I've even I'm still working on them, but I've done some cheat sheets for them in terms of suggestions about goals that they can use for certain problems, and things like that. So that is a challenge. I'm glad you brought that up. Any other questions or comments?
Jane, I have a question about timeliness as part of the SMART acronym.
Yes.
We've been provided mixed feedback about how to exactly meet that part of the acronym within a treatment plan. For example, on the treatment plans, there's the start date for a goal and then a target date for a goal.
Right.
But we've been told that in addition to that, we have to include in the actual written part of the short-term goal that the person will achieve that goal by or within 7 days.
No, that's not true.
Okay. So can you tell us what is true and how we can improve in that?
So Matt is so polite because I told him what to do when they do that. So so it's more likely the people our DMH colleagues that are coming around and so what you have to do, let me go back to the goal examples I gave you, and because it's tricky. It's screen share. All right. It actually drives me crazy when everybody puts within 30 days. Yes, it's in 30 days because your 2 dates are 30 days apart. Okay. So, see, so for the first goal, John will tell nurse he's hearing voices and what the voices are telling him once a day. That is the timeliness. Okay. Ms. Doe, be it 3 times a week. That's the timeliness. Once per day for 4 consecutive days. Okay. For 15 minutes. And so this fourth one here, Ms. M will meet with her attorney and discuss her charges for 15 minutes. That the thing is that that you only need to have them do that once. They're only going to do that once. They're not going to do it like, once a week or something like that. So that's okay. A lot of people have stylistic things. I noticed a lot of people will put within every single goal within the next 30 days. To me, that's confusing because you've got the start date and you've got the end date, and that's sufficient. Okay. So what I told Matt is, but you have to have timeliness. You have to have like how many times a week. If your goal is a week away, you have to have how many times you're going to have to do it. Now, if they say you have to have like within the next 7 days, you can say that Jane did a training with you and she told us something different, so we're doing what she tells us. Because because I'm following all the I've studied the regulations. I know the regulations. And I know who a lot of the people are that are DMH people that are reviewing the charts. In fact, I've done it myself. And some people, it's like the reviewers. You could get a reviewer. So if you get a reviewer who says something like this that you don't agree with, your job is to explain to them how this meets the standard. And we do that all the time. Okay, so that's a good thing to know. I mean, if your creation date and your target dates were all off, then it would be a problem. But if they're correct and they show a 7-day period, you don't have to write within a 7-day period. And if one of the reviewers, because I often get calls after the reviews, if there's something that, they want to clarify with me or teach people about, if that happens, I would like to get a call about it, because I will talk to the person who said it and see if we have a different understanding of things. Does that answer your question?
Yes, but it brought on another question, if that's okay.
Good.
That last example, the short-term goal that the client will meet with their attorney for 15 minutes.
Yeah.
And could you argue that the 15 minutes isn't the timeliness thing, but that's the measurable portion of the goal?
So you could, but we're getting into semantics here, because the whole point of this is that we meet Joint Commission and CMS requirements. Okay, so I've looked up the acronym SMART, and I've even seen different words used for SMART. So the point of SMART is for us to write goals that meet Joint Commission and CMS standards. Do you know what I mean? It's not for us to it's SMART is a tool for us to meet a standard. And I would say that this meets the standard, and that's what the issue is. And like you said, the timeliness is within the next week, because you've got the target date. You've got the target date on the treatment plan. Not every treatment plan has a target date section. If you didn't have that, then you'd have to put it in the goal.
That makes sense. Thank you, Jane.
Okay, good luck. But I would like to get called if people have questions about things. And I have had disagreements about some of this stuff with people, and as we've talked it through, we actually both agree, but it turns out it's semantics. Okay, so I want to move on right now, and we might have some more time before 3:30. I want to move on to the admission documents. And this is mostly for nursing and psychiatry, but it's important that everyone knows this. I'm having trouble here with my mouse. All right, that's it. Okay. Okay, so what I want to do is Are you still seeing my old PowerPoint?
You're not sharing.
No, I'm not.
I'm not sharing, okay. Because I wanna.
It's
if I
there
can
now.
close this, yeah. Maybe. Oh boy. All right, this is not. I gotta find my other PowerPoint. Okay. So I got that, and now I'm gonna screen share. Okay, maybe I can get it this way. Okay, now are you seeing the admission treatment plan slides?
Not quite yet. It looks like you didn't open the document yet.
Oh, okay.
Can you double click it again?
Let me close some of this other stuff. All right, now. All right, new share. All right, I'm just gonna share my whole screen. I don't like to do that, but this other thing isn't working. Oh, now it showed up. Okay, sorry about that. Okay, now you're seeing it, right?
Yeah.
Okay. So these are the new admission treatment planning documents. Okay, so the first one is called the admission nursing care plan, and this is a screenshot of it, and I've got a bigger one if you can't see this. This is going to replace the initial treatment plan that you're now using. You're now doing that on admission. Okay, so can you see this? Can you read this? Is it big enough for people to see?
Yes.
Okay. All right, so this is the nursing care plan. Okay, and it's not a treatment plan. It is a nursing care plan. And one of the attachments I sent out was admission nursing care plan facts, which all the nurses should have a copy of that, and they can read it and explain why we do this. So it's not a treatment plan because it's only done by a nurse and it's not signed by a doctor. So it's not a treatment plan. A treatment plan has to include the doctor, the nurse, and you, the social worker as well, but at the very least a doctor and nurse, and it has to be signed off on. So this is an admission nursing care plan, okay? It holds as the nursing portion of the treatment plan until the master treatment plan is done, which in your facility is 5 days, right? Okay. So if you look at these first two sections, identified risk and risk description, these sections are both in the admission nursing assessment. Now, it looks like you have been using the old version of the admission nursing assessment, okay? There is a newer version that it's out. It works the same way as the one you're using now. And it's a PCS document, and it has sections like this where you click off, you click off things, and then you write narratives underneath. Okay. So what's going to happen is before you do this document, before you open this document, you're going to complete your admission nursing assessment. Okay. So I know you have, when you get admitted, you admit people, you have a lot of documents that nurses do. What we're suggesting is this is the last one you do, because you have to do the admission nursing assessment first. So when you open this up, you click recall values, and all the information that you put in the nursing assessment will flow in. So all these check marks will come in, and the risk description. And then what you have to put in is at least one patient goal based on these risks. And you have to put a target date, which in your case is 5 days from admission, because that's when you do your master treatment plan. And then you have to write in interventions. Okay, so you have to write them. So these interventions that you're going to write in are very similar to how you're going to write them on the master treatment plan. Okay, so here's the below, the description says you write the name of the nurse, and nursing staff will blank for blank minutes times per blank for the purpose of blank. Okay, so that's how you're going to write this. Now I am going to show you next some examples of how this looks in the EMR. Okay, so this is one example. So you've checked off 2 identified risks: violent behavior and self-harm. And then the risk description is the patient has a long history of treatment and med refusal, resulting in disorganization and aggression. She was assaultive towards staff at MCI 2 weeks ago, but has not engaged in self-harm for 5 months. So in this case, because this person hasn't engaged in self-harm for 5 months, okay, you don't even have to check off self-harm as a current risk. But I know a lot of nurses don't feel comfortable with that. They've told me that. So they want to, if it's happened within the last 6 months or a year, they want to check it off. That's fine. You can check it off. But you also have to explain in your risk description when the last time they engaged in this behavior. So this person was assaultive 2 weeks ago. So they're coming into your unit. New, what are you worried about? What's your prime worry? Your prime worry is their assaultive behavior. So that's what you want to target. Okay. So the goal is a short-term goal. Okay. So the short-term goal is patient will engage in 1 2-minute non-threatening conversation with staff twice a day for blank days. Okay. And then the target date is the date the master treatment plan is due. And then the intervention is written like you would write an intervention on the master treatment plan. RN and nursing staff will meet with the patient twice a day for 5 minutes to assist patient in developing and using coping skills when stressed. Okay, so that's example number 1. I've got a couple of other examples. In this case, the nurse checked off violent behavior, and the risk description is Mr. Saunders recently slapped his deacon on the face at church. He has also slapped family members at home. So this person hits people. So that's what you're worried about when they come into the hospital. So patient will use a coping skill he identified on the individual crisis prevention plan to deal with stressful or frustrating situations twice a day for blank days. So this is what I was talking about. This individual crisis prevention plan is a tool for you to use in treatment planning. So when you've done the admission, you've already gone through this with the person. They've already identified some coping skills that work for them. Okay, so you can refer back to that in this. Again, the target date is the date of the master treatment plan, which is 5 days for you. And then the intervention is nursing staff will, RN and nursing staff will meet with patient once a day for 5 minutes and review coping skills he has identified on the crisis prevention plan. Now, there's something very important here that I am going to emphasize next week. And this is something that came from reviews at all of the facilities. I was, all of the facilities in DMH. If you write an intervention like this, okay, so this says the nursing staff will meet with patient once a day for 5 minutes and review coping skills he has identified on the individual crisis plan. You have to document that you did this every day, okay? So whatever you say that you're doing in the intervention, you have to document. And I'm going to talk more about that next week, okay, about how you document it, because it could be in the teaching record, it could be in your regular progress note. So if you say you're going to do something, not only do you have to do it exactly as written, you have to document that you did it and how the person responded. So this is a case of somebody who had multiple risks on admission: violent behavior, suicide risk, homicide risk, and acute medical risk. And the risk description says that patient has a history of above risks prior to hospitalization. The person was at another hospital unit for 8 months before they came in. Currently, he is observed pacing the unit, yelling and swearing at staff when they are unable to meet his demands, and threatening suicide. He is not responding to staff attempts to educate him about not being able to leave the unit and smoke. He has a current issue with cellulitis of his left thigh. So again, you are going to focus on what are the immediate needs. This isn't meant to be a complete treatment plan because the assessments haven't been done. This is just based on the information that you have when somebody's coming in. So in this case, the nurse has decided to write 3 goals. One having to do with their violent and homicidal behavior, because he is swearing at the staff, okay? So we want to deal with that. So patient will engage in non-threatening conversation for staff with 3 minutes twice a day for blank days, okay? And then the other thing that you're worried about is the suicide. So you have a suicide goal. Patient will identify 2 coping skills that he can use when feeling suicidal in the next blank days, okay? And then the third one is that you're worried about the cellulitis. So patient will learn about his cellulitis and need for treatment, okay? And then again, we have 3 corresponding interventions to those 3 goals. Okay. So this is just an admission nursing care plan. It's not a treatment plan. Okay. This is the admission treatment plan. Okay. It has a goal. So what we're doing is we're having the same admission treatment plan for every patient that comes in, but it can be modified. We want to make sure that it includes all the elements that a plan should have. So for a goal, the patient will identify treatment and recovery goals for hospitalization, okay, prior to the first treatment and recovery plan, okay? And then here are the interventions. The nurse will follow the admission care plan that we just saw. The social worker will complete psychosocial history and assessment. The occupational therapist will complete OT functional assessment. Psychology, psychiatry will complete risk identification tool. Medicine will complete medical problem list. And then for physician's orders, see physician orders for the following: medications, lab, diet, vital signs and special instructions. Okay. So this is going to hold us as a bona fide treatment plan until we have our master. And I'll show you where it's supposed to be. So this is the admission psychiatric assessment. Your doctors are currently using this, but what they're not doing is they're not pasting what I had in the last screen under this section here. So see where it says admission treatment plan? They need to paste what I had on the last screen into this section. Okay, and then they can add stuff, and most of them do. They don't have to, but most of them do. And then this is what it looks like in the EMR. This is the last section of the admission psychiatric assessment. And so that's where the admission treatment plan sits. Okay, questions, comments? So if nursing staff is going to need more help with this, I have some other documents. People can email me and reach out to help. But this is going to, on March 1st, these documents are going to be available for you to use. So starting March 1st, you're going to be using the new admission nursing care plan. You're going to use the updated version of the admission nursing assessment. And with psychiatry, I think somebody pointed out to me that some of them are cutting and pasting, but most are not. So what we want to do is, and I'll need help with how to do this, is to make sure that every psychiatrist has a copy of that admission treatment plan that they can cut and paste into their admission psychiatric assessment. What Ann Goldstein did when we were first rolling this out is she sent it to everyone. She also offered to put it on people's desktops, but what the psychiatrist said is they use 15 different desktops all over the hospital when they're doing admissions, so that wouldn't help because some of these things don't show up on their desktop. Anyway, so that is coming attractions. Any questions? Okay. So if anyone thinks of any follow-up questions between now and 2 weeks from now, when we do part 2, just email me, but I will begin the next section by asking if there's follow-up questions. But you can also email me things as well, because that will help me to prepare. Okay, I think you can stop the recording, Sophia.
Okay.